Perfect. Wonderful. Welcome, everybody. We are super excited for you to join us today. Most of you know me. I'm Pamela. I am the immediate past president of the AFMA Board of Directors. And I have my beautiful friend, Dr. Wright, here joining me. We are going to talk to you today about all things ACGME, ABFM, CBME. We have a lot of content to cover in a short period of time. So more and more people keep joining our room. So I will give them just a second here. And I'll give them till 11:02, and then we will get started and jump right into all of this. So I have a conflict that begins at 12:30. Yes, you will have access to this content after the meeting, Robin. Once we're done with our webinar today, it is actually being recorded, and we will post this live on our YouTube channel. So stay tuned for that. You're very welcome, Robin. I see lots of familiar faces here. So welcome, friends. Happy Thanksgiving early. If I forget to say it before we're done today, hope y'all have a wonderful Thanksgiving and spend it with those you love. Okay, Dr. Wright, are you ready? I'm going to let Dr. Wright introduce herself really quick and just give us a brief little bio of who she is and where she's from and all the awesome things that she does, and then we'll jump into it.
Hi, I'm Ray. I have worked with Pamela off and on for many years as part of the WAMI network, and then we had the opportunity to work together more closely and maybe drink wine together a few times as part of the STFM Task Force for Competency-Based Medical Education that is sponsored by the Society of Teachers of Family Medicine. So I have been the Associate Program Director at Family Medicine Southwest Washington in Vancouver, Washington. A big shout out to Krista and Tish for the work they do. And for the last year have served as the interim program director that I hope will be a short-term experience. And I also serve as the associate program director for the WAMI Faculty Development Fellowship. So I'm very honored to get to talk to you guys today. And thank you so much, Pamela, for inviting me.
You're welcome. All right, we're going to get down to business, friends. So today we are going to go over quite a few different things. We are going to start off our conversation today with the objectives and what we're going to talk about today. We are briefly going to go over the current ACGME program requirements. We all know that there are some things that have changed in the last year or so. We're going to discuss competency-based medical education. And I'm just curious if those of you that are on the screen, if you can just do a thumbs up if you know what CBME is, if you're currently doing CBME in your program. Thumbs up. I'm seeing a few thumbs up there. You can use your little reaction keys. So down in the bottom there under react, you can do your little thumbs up. So hopefully all of you are using CBME now within your curriculums. As we know, we live and breathe it now. So, and then we also are going to discuss strategies to address the ABFM outcomes, which is where those CBME competencies are going to come into play. So, the new ACGME requirements, as you all know, and you should be practicing in your residency programs, is that the practice is your curriculum. So it's what you're teaching your residents, okay? You want to make sure that you're transitioning into that CBME that we just talked about, competency-based medical education, and those core outcomes that your program director is now having to attest to when your third years are getting ready to graduate from residency and go out into the world and become board certified family physicians. And then, of course, we also know that one of the requirements for ACGME is that the faculty that we now have to have more dedicated time to the education of our residents and to the evaluation of our residents. And when we talk about evaluation, it's all encompassing and it's multiple ways of evaluations, whether it's electronic, whether it's formal feedback, if it's these direct observations that we're going to talk about a little bit later in our conversation today. So make sure that you're paying attention to all these things and that you know what's going on within your programs. And I know that we're all different and our programs all do things differently, but I also feel like this is very important. And I think Dr. Wright would agree with me that we as administrators and coordinators need to know all these things and we need to know what's going on in the background. So some of the highlights from the RC family medicine requirements is the panel management. We know that that's a big thing now. It's a different type of paneling, but we have to keep track of those things. We also need more continuity for our residents in the clinics. And the whole shift with competency-based medical education is to get away from the numbers, because we all know that certain physicians can see, residents can see a certain amount of patients and be excellent, competent physicians, and other physician residents could see those same amount of patients and maybe they're just not there yet and they have some work that needs to be done. And so the shift with competency-based medical education, these core outcomes, is to move towards being competent and not necessarily just meeting a metric number. Obviously, we also want more resident engagement. We want our residents to be involved in their learning process. We don't get into ILPs here, but ILPs are a big thing, which is their individualized learning plan. And that is a huge place where those residents get involved within their own education and how they're being evaluated and moving through their practice. And then we obviously want more formative assessments, and we will get into a little bit more of that as we shift into more of the conversation today. So hopefully all of you are doing a lot of these things, and if you're not, you're aware of them and you're working with your program directors and your faculty to make sure that you're meeting all of these requirements. So we're going to shift over to the breakdown for continuity care within the family medicine clinic. Some of these things haven't changed, but there are some that have. We all know that our residents have to have a minimum of 40 weeks within the continuity clinic. This one's tough, I think, for a lot of programs, but they're really watching this. And so I feel like it's an important piece to what we do, especially as an administrator. No more than 8 weeks of interruption within their continuity clinics, which is also a big piece. In your smaller programs, sometimes that gets difficult. So you learn to become innovative when you're doing all that stuff. And then, of course, the shift from those numbers that we talked about, the 1650 in the clinic, and now it's a minimum of 1,000 hours dedicated to the family medicine patients that your residents are seeing within their clinics, which is a little bit of a shift. Okay. Then we're going to shift over to the patient-sided continuity. It's 30% for our PGY2s and 40% for our PGY3s, and the resident side is the same. So you're having to track all of these numbers differently. You're not looking at them as an actual encounter. You're having to track how many patients your residents are seeing within their own continuity panels, and it's just a different way of us thinking about how we're collecting all the data. And then obviously the bottom piece there is the panel must be 10% must be under the age of 18, and 10% of those patient panels must be over the age of 65. So all these pieces come together. And the big piece, I think, in all of this, and this kind of sums up the slides here for us, is that the emphasis is on the mission. Okay, we want to make sure that we're doing all the things that we need to do. The community, the service, population health, teaching our residents all of these things within their practice. You want to make sure that your residents are part of and participating in patient advisory committees. This is a big piece from the ACGME, and I think a lot of programs weren't doing this for the longest time. So, and then of course, the diversity within the demographics of your patient panels. Again, we're all different programs. We all are located in different places within the United States. And I'll just speak for my program. We see a lot of Spanish speaking patients. And so, we have a lot of diversity there. We also have a lot of indigent patients who don't have health insurance. We are a federally qualified health center. And so how do we incorporate all of those pieces into each of our residents' practice? And you in your own practices, the different diversity within your program and the demographics of those patients that you have. Other highlights within the clinical experience that we talk about the emergency medicine or the ER requirements were cut in half. They added numbers of encounters instead of hours. Same with your inpatient pediatrics information or your rotations there, cut in half. There's no minimum number of newborn patients anymore, which I think was a big thing for a lot of programs, because a lot of programs I think struggle with doing OB and getting those newborn visits. And so this I think was a huge relief to a lot of programs. Same with the surgery. The MSK experience, musculoskeletal experience, sports medicine, no longer went from a structured hour or time commitment to just having a defined experience. The critical care experience, you have to have that experience. There's no minimum numbers again. Used to be that they had to have a certain amount of hours in that ICU or a certain amount of encounters. The care of the older patient is the same. That has not changed at all, but they've actually added numbers of encounters that we have to keep track of. So the OB stuff is a big thing. I think it's now 2-tiered with different numbers that are required. Used to be that there was a certain requirement of deliveries and such, and now it's more of an experience. And again, I think that has a lot to do with where we are all in different places across the country and how our programs function. Some do more OB than others. And so I think there was a struggle for that. And I think that the ACGME and they've heard us talk and they're seeing that. So the health systems management time is gone, I think, which is a big relief to a lot of us. We just need to make sure that we incorporate that into our residents' education. I know it's big at my program. And hopefully all of you are practicing that as well, teaching your residents how to code and all those things that go on, their contracts and looking at legal documents and those sorts of things. And then the electives times went up. Used to be that we only had to give our residents 3 months of electives in their 3 years of residency, and now we are required to give them 6 months. Some programs give more than that, which I think is great. And the core faculty requirements from the ACGME. If obviously there are more than 13 residents, the faculty should devote at least 60% of their time to the residents and the patient care and teaching them, okay? Exclusive of patient care without the residents, okay? At least 24 hours a week have to be without residents. If there are 12 or fewer residents, they should devote at least 40% of their time to the program, exclusive of those patient care visits, okay? And then the core faculty members should devote a majority of their professional effort to teaching, administration, scholarly activity, which we all love and love to report in our web ads every year, and then supervising the residents' patient care. We have a little poll here, but we found we have a little snafu with our Zoom account. We can't do polls for some reason. And so we're just going to ask this question, and hopefully those of you that are online can just join us in the, just write in the chat. Like you can see the slide here. And so we're curious, which is the most challenging for you as a program to meet? Please just write in the chat whether it's A, B, C, D, E, F, or G. There's the 40-week minimum requirement if you're struggling with that. The long-term care over 24 months, I would say my program, that's probably one of ours, just because we were kicked out of long-term care facilities during COVID and they haven't really let us back in. The minimum 1,000 hours dedicated to your resident seeing patients in your clinic, the continuity side of things, panels, if you're having trouble meeting a certain percentage of under the age of 18 or over the age of 65, or if you're having trouble meeting those core faculty requirements. So please just write in the chat whatever it is that your program is struggling with, and we'll see what we can come up with here. And it looks like it's kind of a little bit of everything, Dr. Wright.
Yeah.
A little bit of everything here. So, and some of you have more than one, which I would agree with. I think I would say the same.
It's really all over the place. I wish we had the poll so we could see the graph.
I know. Well, we have a recording of this, and so we'll be able to have a copy of the chat, so we'll be able to keep track, Dr. Wright.
I think that would be really useful.
Yeah.
All right. Well, thank you so much, Pamela. I'm going to transition us now a little bit to talking about some ways to meet these things. So my program is Family Medicine of Southwest Washington. So that's what FMSW stands for. And we were pretty overwhelmed by some of these requirements, especially the ones that had to do with panel management and trying to think of ways to really integrate that into the curriculum. And so I tell you this not because this is the way you should do it or your program should do it, but just as an example of the kinds of things I think all programs are going to need to do going forward to meet the requirements that are going to be continually coming at us in a different way, I think, as we move away from just that checkbox of how much time residents do things. So what we did to start with is we created a new half day every week. Like a lot of programs have these half days for teaching days and didactics. Well, we added an additional half day to just talk about panel management, quality improvement, scholarly activity, EMR optimization, health systems management issues that because the time had gone away, but the requirements really didn't, and completing modules for their ABFM, all this kinds of stuff that you're trying to fit in randomly. We decided, you know what, let's just get all the residents together at once and do this together as a group. So how did that work out? Well, like a lot of great ideas, it's a learning curve, right? And you have to be willing to look at how things are working, do some surveys, get some feedback, and then readjust. And I think that's the most important thing. And so we realized that the resident schedules, because we scheduled this half day in the morning, that it was really impossible to free people up from the inpatient services. And we thought, well, that's not going to be such a big deal, but it kind of was, because then there were too many people missing the same information, and we were struggling to figure out, especially with panel management, how to do that as a group. We also realized that the faculty who was running this needed some outside help, and it was really difficult to get people to be available to come in and help mentor that. The faculty champion, no matter how hard she worked, there was really never enough time to do all this, and we didn't have really administrative time built for her, so that was kind of unfair. But even in the midst of all that, so behind the scenes, as typical, we're all struggling, but the residents thought, oh, this is really cool. We love this. We're learning a lot. Especially, it's great that we're learning more about what the EMR can do, not only the optimization for seeing patients, but also how to run reports and things like that. So we didn't want to get rid of it. From the resident perspective, it was a success, and we knew these things needed to be done. So we thought, okay, let's take it out of that half day thing is more trouble than it's worth. And so we pulled it back into a half day when we normally had already, this didactic teaching half day that's weekly. And so every other week, we're going to focus on clinical topics one week, and then we're going to focus on these other topics the other week. And then we're going to make sure that the residents are freed up, because they were also complaining on their ACGME survey that they didn't have enough time to go to didactics. And so we're going to see how it goes. So that's what we're started this year. And I can report back next year if you want to see if it was a better success. But so far, so good. So just thinking about how you want to update your curriculum in creative ways, and just try things out. Be creative, and don't be afraid to try things, and then don't be afraid to back away when it's not working either. So competency-based medical education, what is that exactly? And Pamela did an amazing job talking about some of the core tenets of that. But when she was talking about it, she was talking about it from the standpoint of what ACGME requirements were before all this competency-based medical education talk was going around. And so it shows you that ACGME planned for this, that this was coming, and they updated their requirements. And just to remind us of what some of those things are that are inherent to competency-based medical education, and also were part of the ACGME requirements. So that idea of focusing on competence rather than hours and rotations. There's this focus on flexibility for residents and residencies, hence things like just experiences versus a rotation on something, more elective time, et cetera, building in that flexibility. The core faculty definition was meant to increase faculty time dedicated to education and administration to the program. And then the requirements of things like ILPs to increase resident engagement. So it all makes sense now. It's like, why did ACGME change all this stuff? Well, it was because they wanted to move us in the direction of competency-based medical education. So competency-based medical education is made up of several different components, one of which is this idea of the learning experiences being tailored to competency. And so what do we mean by that? Well, number one is that we want the experience to be progressive. So it's not enough to just say, okay, the residents spent some time doing this as an intern and now they're done and we're never going to come back to that again. The idea is that they're going to spend some time doing this and they're going to keep spending time doing it, and they're going to progressively be giving more responsibility, and the expectations are going to be higher, which means they need a lot of ongoing feedback. So making that curriculum so that you're something built around something called entrustment, meaning that as they go along, you're going to trust them more and more to do the things they need to do, so that when you turn them loose into the world, you're not going to be afraid for them to take care of your friends and family. And then that flexibility to accommodate all that variation is where the electives come in. So electives are not meant just for residents to say, oh, I want to do more wilderness medicine and I want to go off and go climb Kilimanjaro and do a global health elective. I mean, that's really cool. And if residents are, just flying high, being able to do all the stuff they're required to do, then maybe that is appropriate for them. But for a lot of residents, as we know, they're actually struggling in something. And so they need to be made aware of where their struggles are and be given very specific information. And their electives need to be targeted so that they don't get off track as they go along. And then what does success look like in the end? When we say we want them to be on track, we want them to be on track to meet the 15 outcomes. And we'll talk a little bit more about that. So before we get there, I want to bring us back to the individual learning plan. So a lot of programs had these already, but they were mostly used for residents who were struggling in some way or another. And so the individual learning plans that ACGME now requires and that are directed towards this idea of competency-based medical education are not that. They're for every resident. They're meant because every resident is on a different trajectory and a path, and they need to be reflecting on how they're doing moving forward. And then they need to be thinking about how they're going to get better, because otherwise, once they graduate, we worry that they won't continue to grow as physicians. And with the way medical information is evolving so crazy fast now, we have to make sure that when they graduate, they're not just, that's where they are. They need to be there and they need to keep going and keep up with the changes. So we have to teach them how to do that. And so we want their progress to be resident driven as much as possible, because we want them to be the ones who own it. We want them to be engaged in the process. But that doesn't mean that they're not held to a standard and that their individual learning plans are just something they do off on their own. And then maybe their advisor looks at it occasionally. It's meant to be facilitated because, like the rest of us, we don't always have insight into the areas where we could do better. I know it's certainly true for me, and I think that's just a human characteristic. So ideally, the residents start off, they reflect like, I think I really need to work on my agenda setting for a patient visit because I'm always running behind. I need to really work on getting my notes done in time. Whatever that is, you're hoping they're going to recognize it. But if they don't, then the faculty needs to lead them to that, and then they can update their individual learning plan together. The faculty are really just facilitating it. And I think we all know that most people who improve quickly, most of our residents who improve quickly, do this naturally. They're taking ownership, but it turns out it's not, doesn't come natural to everyone. So we're trying to help people move towards that. So obviously that requires advising and coaching. And in the past, our advisors were really all doing slightly different things. And so I think every program needs to look hard at what their advisor strategy is and what sort of skills their advisors have, whether their advisors are functioning more like mentors or they actually academic advisors that really understand how the evaluation system works, where their residents are on the trajectory towards outcomes. So that's going to require a significant amount of time for our advisors if we're going to have them do that sort of thing. And because in the end, we have to be able to recognize that where our learners are, because they're all moving at a different place, identifying where they are when they get here and how close they are to getting to those outcomes. And so the residents need to be coached. So ideally, advising and coaching would go together, but coaching is something that faculty development is essential for. So start looking for opportunities for your faculty. If they say they want to learn more about coaching, say you go, because that's going to make your life better. Because I think that one of the hardest things for you and for the residency director is when residents need an improvement plan. That just sucks. It's just a time sink. It's depressing. It is just a lot of work. And if we ignore it, then it just gets worse. So this is meant to be, this is a big deal because hopefully it'll help that aspect of residency training. So in summary, residency training in the age of competency-based medical education is about progressive competency. So making sure that we're keeping track of where residents are from the beginning and giving them feedback and seeing where they are, using their elective time to help them catch up when they need to as they go, which may mean scheduling your electives a little differently, using those ILPs to engage them so we're not just telling them what to do, we're hoping that we can lead them to the idea so that they're the ones helping plan what they need to do to get better before they go to an improvement plan. And then to always keep in mind that in the end, we're targeting those 15 outcomes. So what are the outcomes and how did they come about? And just as a quick reminder, I've been around forever. I started doing faculty work in the year 2000. And so it's been 24 years. And I can tell you when I started, there weren't even 6 competencies yet. Those came out in like 2002 or something. And so the 6 competencies, we were like, what? We got to rearrange our goals and objectives and our evaluations on these 6 competencies. What does that even mean? And the language was weird, but that's what it was. And then about the time that became old hat and we forgot that it never was a new thing, they decided, well, let's break these down into sub-competencies because programs are all defining competencies. They're too broad. People are defining them differently. They're becoming meaningless. So they broke them out into those sub-competencies, not just for family medicine, but every specialty now took the same 6 competencies and divided them differently for the sub-competencies. And then within those sub-competencies, they took those out and said, okay, what are the little skills? What are the micro skills that they need to be able to do within each one of those that they're going to progress in? So the easy stuff first, like they just have to understand things and list things and describe things. And then towards the end where they sort of start to role model it. So those were called the milestones. And each subcompetency, as we know, has different milestones. And so a lot of programs complained. It's like, well, we still don't really understand what these mean. These are vague. These are hard to measure. So they updated them and made them a little better. Still a little vague and hard to measure at times, but I think most of us are putting our own spin on it, and that's the way it's meant to be. That's why the CCC was a new requirement at the same time that the subcompetencies came out. And then now we're adding this thing called outcomes. And so I get a lot of questions at meetings about whether or not the outcomes are replacing all this. And the answer is no, because they're very different things. The outcomes are really the graduation target. And these are the things you want to make sure that in the end, your residents can go out into the world and no matter what practice they're in, what town they're in, who their patient population is, there are these certain things that they are qualified to do, that they are competent in already. And the milestones are just the skills they need to get there that are progressive. So your milestones you need to be measuring from the day they arrive during orientation and then following those to see how they go, knowing that in the end, they've got to be competent in these 15 things, and these milestones are going to help them get there. So I hope that helps explain that a little bit. So the first 5 outcomes we've already been through this past year and reported on those. And they started out with these 5 because they're kind of the basic things that every resident is going to have to do. And they thought it would be easier to measure, comprehensive care, acute care, comprehensive care of children, those well child checks, being good communicators, being professional, things that we should be able to expect from day one. And then next year, at the end of this academic year, 2025, they've added some things. So the first 5 we're going to have to report, and the outcomes are reported to ABFM as opposed to ACGME, that we're going to have to report on musculoskeletal medicine and preventative care, priorities of care, the sort of the post forms and all that, and the chronic medical conditions, being able to be a good team member. And then for 2026, they're going to add 5 more for the total of 15. And then finally, women get involved. I think it's funny that all the female stuff was added at stage 3. So care of women, care of pregnancy, procedures, and then all this lifelong learning. So it gives us some time to ramp up to really learn how to do coaching and ILPs. And that's why the lifelong learning was added last, is to give programs time. And so again, milestones and subcompetencies are ACGME requirements for programs to make sure that we're following and reporting. The outcomes, however, are ABFM. So per resident, we have to report those. And if the program director says, I just don't think they're there yet. I don't think they're competent in being able to do any basic procedures. They just don't have the hand-eye coordination. Well, then they may not be able to get board certified. So we have to get them there. You don't want to identify that at graduation. You want to identify that during their internship, and then give them some elective time and special attention so that by the time they graduate, your program director say, yep, competent, 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 times 15. All right, so competency-based assessment. So I've been talking about, we need to be able to give this feedback and see where they are on this continuum. So how do we do that? So number one, we have to do it a lot. We need to be able to do it in different settings, and when they're in inpatient medicine, whether they're on their elective, whether or not they're in clinic, and mostly when they're in clinic, because that's where most of them are going to spend most of their time and where they should be spending most of it now. It needs to be based on observation, not just this end of rotation thing where that your faculty don't really remember what the resident did, especially if they're turning in their evaluation 3 months late already. Not that our faculty would ever do that, but I've heard tell this happens. So it needs to be based on observation in the moment. And that's what that formative assessment is. Formative assessment is not summarizing what they did over the course of time. It's in the moment. You just saw this patient, and the way you presented the information was very confusing for me, and I'm giving you this feedback. And then we've got to start recording that a little bit because people do not remember. They think they will. So building in strategies to do that, which means we need to start modifying some of these tools that we're using and getting rid of the ones that really don't give meaningful information anyway. We're not just adding, we want to add and subtract and kind of prune it. And then there's something called entrustment skills, which we'll come back to, that are helpful in this process. And in the end, you want your clinical competency committee to be able to take the information from assessments and make recommendations that they feel good about, so they're not just making it up on the fly during the meeting, and that they're really talking about how the residents are moving towards those outcomes. So assessment, if I say more, that we need more, how many do I mean? Well, there was a big survey that was carried out by ABFM, and they got, I forget, I think it was like 400 responses to this. So it was pretty accurate in terms of how many programs responded and participated in the survey. And the average number of assessments done per resident at graduation was somewhere between 50 and 75. And then they looked at the Canadian model and thought to themselves, well, Canada has been, and we don't want Canada to beat us on anything, right? That's not where we are. We're Americans. We're the best. And so the idea that they had been doing competency-based medical education first, we looked at it. They have about 500 assessments done per resident at the time of graduation. It's like, how the heck do they do that? Well, obviously they're doing little short and sweet assessments. There's no way they're doing 500 of these like 2-page end of rotation evaluations. So we don't need to get to 500, but we need more, and we need to figure out ways to do that with these shorter, sweeter assessments. All right, so just to kind of explain how the thinking is, as we've been building and thinking about how to do better assessments, there's this feedback pyramid that we put together as a task force. And the idea is that in the sort of world of evaluating our resident, that feedback that they're getting all the time, they don't even notice they're getting it. But faculty are constantly saying, good job, uh, or maybe do it a little bit like this, or make sure and go back and ask the patient this. These little bitty nuggets of feedback, and we just have to structure that better and take that and document what we said and make it very specific and watch them do things more. So, because it's hard to give feedback on a physical exam based on what the resident reports to you because you didn't actually watch it. It's going to be much more meaningful. So even if faculty can go in the room for just a minute or two and during precepting and watch somebody do something, and then find a way to record that. And then so that's really the best we can do. The more of that we can do, the better. And then the next best, I think, is something like shift cards or end of day evaluation. So it's still fresh in their mind, and both fresh in the mind for the evaluator to be able to record it, but also when the resident hears it, they know what they're talking about. It wasn't something like, I don't remember that. Everybody remembers that it was just today. And then the end of the rotation should really just be a summary of all that, no surprises. If they're getting all this other stuff before they get to the end of rotation evaluation, I mean, you could honestly probably run a report if you had enough of these and call that your end of rotation evaluation. And then the semi-annual evaluation, the same way. By the time you get there, there should be no surprises because we've been giving such great feedback that was structured and documented all along the way. And then when it's time to graduate and report those outcomes, the director knows exactly where everyone is, and so do the residents because they've been getting this information all along. So direct observation, I've mentioned that several times, and that a lot of times programs think about that as where somebody's having to watch them just sit and do a whole day. It's like, oh no, we don't have enough faculty to do that. There's no way we can schedule that. So we had to come up with strategies to sort of work around that a little bit. And so we thought about, well, we do this already for procedures, because we have to bill for it, right? And so when residents are doing procedures, there's almost always a one-to-one for most of the procedure. And so how can we do that for other things that are equally as important? And then we thought about, well, the other place we do it is when for these like simulations like ACLS and BLS and OSCEs and things like that. But those are very time intensive. So we can think about the principles, but we can't actually do it that way. And we all do some of this one-to-one precepting. And, ideally we'd be doing that all the time. But again, it's too resource intensive to watch an entire half day or even a whole visit. So the idea is these encounter snapshots. So when your faculty's precepting, you don't need an extra faculty somewhere. If they can just walk in and watch part of the history or part of the physical exam, if a patient comes in for knee pain, if they just watch the knee exam and then they have a quick way to actually document this, that they gave feedback on that. And as you collect all these little nuggets every day, all the time, collectively, they give a nice, well-rounded picture of how a resident's doing and the residents getting feedback so that they can also improve in real time. So why are we doing that? Well, the other reason is because it's more objective. You're not just guessing how they did, you watched it. So there's less bias. We're always talking about how do you minimize bias in evaluations? Well, one way to do that is to give it in the moment after you've watched it so that you both are talking about the same thing. It also allows for earlier improvement, and it's incorporating teaching. Feedback is a form of teaching. It shouldn't just be telling someone how they did. It should be a conversation. I just watched you talk to this patient. I noticed you were looking at the computer the whole time. Tell me a little bit about that. And say, oh, and hopefully they'll realize they didn't realize they were doing that, and they can, or they'll say, well, actually, this patient always gets way off track, and so I was trying not to make eye contact because I knew I'd get stuck in there forever. So it has to be part of a conversation. So we invented a mobile app, and this is something Pamela has been very involved in. So I'm going to turn it over to her now to talk a little bit about the mobile app.
So the mobile app, most of my friends are using the New Innovations app, but I know that there are a lot of different mobile apps that are out there. And I want to give a huge shout out to Dr. Wright because she actually was instrumental in this mobile app with new innovations. And she's also been working very closely with MedHub. But the STFM task force, one of the things that we were tasked to do was to create this mobile app and be able to have direct observation forms, or a way for us to give feedback on our residents in the moment, as Dr. Wright just mentioned, to be able to document things as they were happening instead of waiting months and months for them to document and give a summative evaluation. It wasn't something that was happening in the moment, and we wanted something that was direct and available at their fingertips. And so one way to do that, obviously, is to use a mobile app. And when the faculty is with the residents and they're in the moment and they're seeing the patient, they can pull up that app right on their phone. They can fill out that assessment tool right away. And it's been very helpful. There's lots of different mobile apps out there, so don't feel like one is better than the other. All of us at our institutions use different software, and so we have to use what we have and make the best of it. Lots of different apps out there. There's MedHub, there's New Innovations, there's the M3 app, there's the Simple app. Keep in mind, a lot of these things cost money. And so we as institutions have to use what we are given. And so programmatically, we are looking to make our residents' education better and to make it simpler. And how are we going to go about doing that, right? So if your program is using MedHub or New Innovations, you are going to be able to have your resident, if your faculty in the moment doesn't have their phone out, the resident can say, I want you to fill out this evaluation on me, and they can send them. They can tell them, I want you to fill this evaluation on me, and it goes right to the attending. They can fill out that evaluation, and they're getting that direct feedback in the moment. Okay. And it maps it right to those core outcomes that Dr. Wright just mentioned, those outcomes that our program directors have to sign off for our residents when they graduate. It also maps it right to those sub-competencies within the milestones. And the cool part is, within New Innovations and MedHub, is that those reports are available to you at the click of a finger. It's a work in progress, but it has been such an instrumental tool, I think, and we've rolled it out over the last year, and we've gotten lots of wonderful feedback on it. I know there are a couple programs where the administrators were struggling on how to set it up or how to make sure that the evaluation was available to them, but New Innovations was huge in rolling this out and walking people through how to do it, and it was right off their homepage, and it walked you through the steps, and I know that MedHub is working on that as well. And so we have created this brief little poll. We'd be interested to hear what you feel that your current assessment tools are working, if they're working well for your residents. Are you very satisfied, mostly dissatisfied? Keep in mind, all of us do things differently. And I think there's a lot of programs that still aren't using this direct observation tool. And I think it's going to change. It's going to change a lot of things for us as administrators, but I also think it's going to change a lot for our residents and for our faculty, because they're doing it in the moment and they're not forgetting things that are happening. And the residents, I think, are getting better feedback so that they can shift their practice and focus on the things that they need to work on, and not necessarily on the things that they think they're super great at, because sometimes the things they think they're super great at, maybe they're not. And maybe their faculty and advisors are seeing those things, but they're not putting them in those evaluations because they're forgetting about them in the moment. And so this direct observation tool is a big thing. All right, we're getting some feedback here, Dr. Wright.
Yeah, it looks like mostly B, so mostly satisfied.
Mostly satisfied. Yep.
Yeah, and I hope they're mostly satisfied because they're already using these direct observation tools, or have some that they're using effectively, and not because they're satisfied with their end of rotation evaluations, because that is definitely, this is going to get pushed more and more, not by us, but by ABFM and ACGME. And so we've got some time to get it right. And if we all work together and share ideas. Somebody asked a really good question about the ACGME app. It's called the DOCC, I think is the name of it, Direct
Yep.
Observation Clinical Tool or something. And we actually looked at that as a task force, but it was really user unfriendly. But we actually took a lot of the content to make this one that we have in MedHub and Innovations. So the content from that we felt was really useful. And so we designed ours to mirror some of that. Also, the problem with the one that was on, you couldn't, the reports didn't integrate with New Innovations at all or MedHub. You could run separate reports, but you couldn't like pull data in for the CCC where it all tied together. And outcomes, of course, weren't built into it. And so I actually talked to the people who made that app and were pushing it, and they said that they did not think that they would be able to do what ABFM was hoping, and that gave us the blessing to make our own. So speaking of tools, if you want some new ones, or you have some that you think are great that we should know about, then please email Pamela and let her know. This link here takes you to the resources from the Society for Teachers of Family Medicine task force for all of this work. It has, IOPs, assessments. It has some of the theory behind things. There's built-in recorded faculty development about coaching. So really anything that you can think of that we've talked about today, there are a bunch of people working behind the scenes to develop this material. And one of the things is called the Outcome Assessment Starter Pack that we put together as a group. It looks a little bit like this. So as you can see, this is the first outcome about practicing as personal physicians. So the Outcome Assessment Starter Pack that's on the website is 15 pages essentially, or 15 blocks. And so this is an example of one of them. It shows how this particular outcome is actually mapped so it's mapped to patient care 2, 4, and 5, systems-based practice number 2, practice-based learning improvement number 1, etc. And then over here where you see the little check boxes, these are different kinds of assessment tools that most programs are already using that can be used to address this particular outcome. So when your CCC meets, you don't have to start from scratch. You can say, oh yeah, we're doing direct observation tools, and we do billing and coding reports and chart review. So those 3 are good. Let's just use those to help answer how they're doing on this outcome. So that's just, again, it's a reference for you to use. It's not required, but it might be helpful. And if you are going to update some of your evaluation tools, then there are the ways to do it that are better are really getting away from these Likert scales. Likert scales are where you're talking about how much you agree or disagree, or not very good to very good, and it's just so biased. You take 15 people and they can watch exactly the same thing, and they're all going to give a different number. And so what is better, what's more useful for residents, are using things like narrative comments, but those are harder because they don't give you scores. And at CCC, I was like scores, or at least having behavioral anchors so that each score on it, as everybody's using the same language to describe what a 2 is or a 3 or a 4, not just saying on a scale of 1 to 10, and then using these things called entrustment scales. So, and in general, I think that core faculty are really good at using direct observation and using these sort of progressive scales, meaning this is where they are and this is where they should be, and this is what their trajectory is. They can use all the other tools as well, but if you're going to focus on some of the tools that are trickier to use, don't have your community preceptors do those. Save those for your core faculty because you can teach them how to do that well. So not every tool needs to be used for every person. It's okay to have different tools for different people. The community faculty, honestly, just the text is probably better because you don't want them having to interpret any kind of grade scale. You really just want them to tell you how the resident did in their own words. And then of course, staff, your medical assistants, nurses, et cetera, because we're required to do that 360 evaluation. Then the questions need to be very specific for what the work they do with the resident, so it can be interpreted effectively by both the resident and the faculty. and also text boxes where they can just write in their own words is more useful for theirs. So focus the fancy grade skills for the core faculty and things that everybody's going to interpret more similarly for community faculty and staff. And then I talked about that entrustment scale. And so just as a reminder, if you don't know what that is, then entrustment scales are a scale of 1 to 5, where a 1 is the resident's never done it before. They had no idea where to start, and mostly they just watched. So maybe they've never delivered a baby before. And so the first time they go, the faculty is probably not going to let them just do it while they stand on the other side of the room. They're going to talk them through every step of the way. So they would be a 1, and that's okay. That's where they should be. What's not okay is that at the end of their second year, they're still a 1. So that's why it's called a progressive scale, is because the next time they do it, they maybe will be a 2. And then maybe they'll stay a 2 for that rotation. But then the next rotation, they come back and they might still be a 2, but pretty quickly they should be a 3. And then by the end of that rotation, they're probably going to be a 4. And but by the time they graduate, they have to be at a 5, or at least a 4. It depends on what the thing is. If you're worried they're not competent to do it, then you should not report that they are to ABFM. So at least a 4 and mostly a 5 is where they need to be and entrustment skills are what ABFM would prefer us to use when possible. All right, I think this one's for you.
Yeah, so we've been talking a lot about CBME and all of these crazy things that are now required of us from the ACGME. And we know it's a lot, and it feels sometimes like it's daunting, and we just figure out the system and we figure out a way of doing things, and then we have new requirements. And so what we ask for you when you're implementing all of these things is to network with each other and share ideas. Make sure that you're on the right path and that you're moving in the right direction and that you're not moving backwards, because I know a lot of us feel like sometimes we take 2 steps forward and we're making progress, and then something else comes out and we're like, oh, we just did this and now we have to change that because we're doing it differently. So use your resources, work together. And obviously the 4 little blocks here that we have for barriers when you're implementing your CBME within your program is the faculty training. You want to find time for your faculty to do their faculty development. And we all know that that is challenging. It's hard to get them all in the same room at the same time. So be innovative when you think about how you're going to do your faculty training. Maybe it's that you're doing recordings and that you're sharing those recordings and that they're required to watch them, or that they can join virtually. I know that that's been a huge success for my program, because a lot of times if we're having meetings and they can't physically be in the building, they miss all the content. And so if you can do it virtually and record it, it's a huge help. Also find champions, find those faculty champions who are good at certain things, and some are better at things than others. And so you want to use those champions like Dr. Wright. She's been a huge champion in all of this across the country. So also your system resources, we all struggle with that as well. We have to use the systems that we have available to us. And so we have to learn how to work through them and make them work for the best of the abilities that we can and get the information out of it that we need. So updated your assessment tools. So using these tools that we just talked about, it doesn't matter what software system it is that you're using, whether it's New Innovations, MedHub, the Simple app, the ACGME app, whatever it is that you're using, make sure that you are using it and you're using the most updated tools that are available to you, because that's important, because the data is important for us when we do our CCCs, as Dr. Wright just mentioned. I know my program, we just did part of our CCC, the other part will finish up in December. And this information, this direct observation stuff is imperative when we're doing those clinical competency reviews and filling out milestones for our residents. And of course, you want to make sure that your residents are engaged in this process. And so that's where that ILP comes into play, and the residents are being reflective in their learning, and they're getting all the information in a current and accurate and the most up-to-date time frame, so that they know where their education is and where they are lacking in their education and how they can tailor those electives, as Dr. Wright mentioned before. So So moving forward, we want to recognize the fact that this is a daunting task. We know Dr. Wright and I have been in the thick of CBME for 3 years now. Has it been, Dr. Wright? I think almost 3 years now. We've been doing this task force. And so we know it's a daunting task, but we have made hurdles, leaps and bounds moving forward, rolling out CBME and this direct observation stuff across the country through residency programs. And so know that it's a gradual process. This stuff doesn't just happen overnight. And the tools that you're currently using, maybe you can tweak them to make them work better for you. Use efficient tools. Work smarter, not harder, is what I like to say. Use those mobile assessment tools that are available to you. Use those matching tools. I know I'm a new innovations guru, and so we do all this stuff, setting it up to manually match, or for the evaluator to be able to just to go in and pull a resident to evaluate, and they can do it on the fly and in the moment. You also want to make sure that you're training the supervisors, the coaches, the advisors on how to do all this stuff, and the residents who are the learners. You know, sometimes they're the ones who have to start the process. They have to say, oh, I want you to evaluate me on that, because they feel like they just did something really great and they want it to be documented. And sometimes the faculty just don't, they don't think about it in the moment. They're just like, oh, you did a great job, and an attaboy on the shoulder, and they go about their way, and nothing is ever documented other than that verbal. And sometimes you want it on paper and you want it documented so that you can pull that information, because sometimes what the resident is hearing and what the advisor is actually saying could be two different things. And so having that direct observation in the moment in front of you is important.
Thank you for helping to really focus on that, because I do think that assessment is the key to CBME. So I'm going to move pretty quickly through these last few slides because I want to have at least a couple minutes for questions. So making sure that the CCC is really up to date on all of this work, to make sure that your orientation schedules are also reflecting CBME. The R1s, they're a clean slate. They don't know what we used to do. So making sure that they are focus your efforts on them. They understand milestones and outcomes, that they already have their ILP starting day one if possible, that they understand this idea of master adaptive learning so that they're really focused on their schedule in a way that helps them to improve and not just waiting for the program to spoon feed everything to them. And then to also understand and think about panel management. And then, so if you I think Pamela already sort of addressed this at the beginning, whether or not you're ready. These are the things that we would say that you need to be ready. You need to be able to address the outcomes. You need to make sure that you are making faculty development available and facilitating that. That you are using the STFM toolkit whenever possible. Nobody needs to start from scratch. That you incorporate more direct observation, recognizing it doesn't have to be an entire visit or certainly not an entire half day. This is going to be an ongoing process with all of those assessments and updating your tools when necessary. And we're all in this together, so it's going to happen. So with that, we've got 2 minutes. Pamela, is that enough time to do any questions?
That's enough. That's enough. Sometimes we get lots of questions and sometimes we don't get any questions at all. So we're going to open it up to all of you. And do any of you have questions for us on CBME or the core outcomes or any of the ACGME requirements? We're more than happy to answer questions for you, or you can shoot us. I put my email in the chat there. If you have questions, by all means, please feel free to email me. You all know my cell phone number. If you don't, I'll put it in here as well. And text me. I'm more than happy to answer texts as well. It's kind of quiet over there. Everybody turn your cameras on. Plan to use this webinar recording for faculty development. You're very welcome, Margarita. We're more than happy to talk to your faculty too, if that's something that you're interested in. Dr. Wright is a wealth of knowledge. She has been doing this, as she mentioned, for a very long time. She's been a faculty since 2000, she mentioned. I've been in my role since 2000. I started my job in 1998 and in my current role since 2004. So I've been around a while too.
Thank you. Thank you very much.
You're very welcome. We
Thank
felt
you.
this was an important topic to talk about because I think a lot of administrators and coordinators don't see this side of things. And it's important that you know this information and you know where your faculty are coming from and your program director. And it's key for you to be on board because you're the one in the background making all the things happen.
We all know that it's the residency administrators that make it all work. I know that. I've been around long enough to know that. So I think that Pamela and I both wanted to make sure that you were armed with the information that you can help steer your faculty and leadership in the right direction. So thank you all very much for having me.
Thank you, everyone, for joining us.